Hey everybody, welcome back to the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Ray Pace here to my right, and we got dueling docs here yet again. We got, of course, our regular Dr. John Hill, and returning third, fourth time, something, many times. So, Dr. Don Spanner. Hey,
Hello.
thanks for joining us. We we find ourselves here today in response to some national news, right? And that is a field death situation that went suboptimally, and so we felt it prudent and timing and whatnot to get out something about field termination, death, DOAs, um, all the things that revolve around in that space, and it's a lot of it's really entangled, and there's a bunch of overlap, and that's really what we want to kind of cover today is start kind of pulling that apart and hopefully make some of this a little more clear. It's nuanced. There's a lot to it, so it's not like it can be 100% black and white, right? But we can at least hopefully get some ideas out into the podcast world and where we're at with field death termination DOA kind of situations right now. So
And it's not. It's yes, it's recent news, but not the first case of its kind, right?
right, it's
There's
not a
been
unique case.
correct. There's been
Yeah.
many cases throughout the United States, some in Ohio, some other that have the same kind of undertones of patient care and touching your patient, those types of things that we'll get into.
Right. Well, I mean, let's talk a little bit about just, and we'll give a summary of kind of what happened in that case. I know you watched most of the footage on it.
Yeah. So the case we're talking about involves paramedics responding on scene to a woman found down, complicated by an animal that was in close proximity.
Yeah.
Took a while for them to clear the animal, which is a whole other conversation unto itself. When they got the animal cleared, the paramedics on scene went to go assess the patient. They quickly declared them dead. Called in a radio call, which is interesting that this uses radio communications and not cellular
Not telephone.
communications. But recorded both by officer video cameras as well as radio recordings. Paramedic called in, requested for a time of death on a patient, reported that the had no pulse, was apneic, that there was signs of lividity but no rigor. Um, with the investigation later on, so the doc on the radio declared the patient dead at a certain time. Because it was early in the morning, it was a young person. It was a coroner's case. Representative from the coroner came out, who happened to be a nurse, an advanced EMT. Started to take pictures because they were treating it as a crime scene like they always do. When they were taking pictures, noticed some movement of the chest and abdomen. Thought, who knows? It was just a trapped air.
Trapped air. Yep.
Rolled the patient's head. Air came out. Maybe trapped air, nothing. And then the person noticed the patient was actually breathing.
Yeah.
Started resuscitation, gave them Narcan, bagged them, called EMS back to transport the patient. The patient was actually not dead.
Right.
So this is not, as I said before, not a unique case. This is not the first of its kind, but we see them every few years, and definitely something we don't want to do. It's not providing the best care. That's a basic summary of what the case was.
And to frame this up, this happened in Ohio,
Yep.
and this is, of course, we're
Ohio.
Ohio entity, right?
Yep.
But I don't know where you're watching. So specifically, we've got some overseas viewership and whatnot. But in the state of Ohio, paramedics we don't pronounce
Yep.
in the field, right? It's in concert with medical control with
Correct.
with a doctor, right? So we can give you the assessment and give you all the key points, but we don't actually make that time of death determination. Hence the radio call and
Correct.
whatnot. The other, that brings up a unique point: is should these calls be not on a radio, right? Is this one that we probably should strive for a telephone call rather than a radio call? Because there is some inherent. It's one thing if I'm bringing you a trauma and I just basically yell, "Hey, I'm bringing you trauma into my radio."
Sure.
Yeah, you want some other information, but is there more nuance that it probably that full duplex communication with a cell phone might be more beneficial in a case like this, and have a
More
have
of
a
a conversation
conversation about it rather than just hey, we need a time of death on a dead person.
Well, I think the physician that's taking that call, I'm not as concerned about how they call,
Sure.
radio versus phone. Rather, what is the information that you're giving that physician to help make a final decision on a person?
Right.
And so the information has to include, a rhythm strip, asystole. I find a lot of people don't understand the term lividity, and they mistake it for mottled skin or even cyanosis. And for that reason, using the term lividity doesn't always convince me because I take these calls all the time. When a paramedic calls me up and says we have asystole and 2 leads, if this wasn't a DOA, for example, if it was a field termination, we've made efforts for 20 minutes. This is what we've done. There's been no response. It was not a shockable rhythm. We did not witness a cardiac arrest, because that's basically what we're asking our field providers. Was it not witnessed by you? Was it never shockable? And did you not get ROSC in 20 minutes? And if they meet all 3 of those criteria, I'm quite comfortable when they tell me we have asystole and 2 leads that I'm going to field terminate. For the DOA, if they give me that information that tells me up front, and I'm not so concerned with rigor or lividity. I want to know, is there any heart beating? Is there any breathing? Is there any response? That's way more satisfying for a physician who's going to give you a time of death than just trying to describe something that I can't see. And so again, to answer your question, I don't really care if it's on a radio or a phone.
How they get that.
I need the correct information.
Just good information.
Correct.
I take your point. It's sensitive information. You don't want someone who's listening to publicly available air traffic, right? That could be listening in to say that, oh, that's my loved one.
Sure.
It's rare, but it does happen. But, I mean, this information should be pretty anonymized, right? You're not giving names out over open airways.
Correct.
Or even on telephone calls unless it's pertinent, right?
Right.
Sex, age, last known well, and all the things that Dr. Spanner talked about. So I don't think if it's radio versus cellular phone call, I think that it goes back to, and we've talked about this before during the documentation one, is just good communication, right?
Yeah.
Good, clear communication, giving a nice, clear report, right? And I've had discussions with EMS providers throughout my career where I run into the squad the next day. They're like, man, you really gave it to us on the phone. I'm like, I said, I'm not there.
Right.
You need to paint me a picture of what you see on scene so that way I understand. The most recent one I had was one of my medics is like, man, I could smell them getting out of the truck. I'm like, you didn't tell me that on the phone.
Lead with that, right? Yeah.
Like, hey, any time of death? Well, they haven't been seen in like 3 days. I'm like, they don't have a pulse. I'm like, okay, do they have a do a 3 lead on them? No. I'm like, they're decomposing. Okay, well then, there's your time of death. You have obvious decomposition.
Yeah.
But if you would have said, hey, doc, I'm John, I'm calling for time of death, patient's decomposing, I can smell them getting out of the truck, no one's seen them in a week, I can see their insides, it's liquid.
I would not be asking for 2 leads.
right.
That's a different conversation. Then I just came upon a body and no last known well, it's all in place, it's cold to the touch.
Right, exactly.
Questionable lividity, which we can get into the modeling and bruising versus cyanosis versus all the other different skin things, which most ER doctors and myself hate skin, versus rigor and all those things. That's complicated.
In your response, Dr. Spanner, you kind of started working through how a radio report for a field termination should work, and then we have this conversation about DOA, and I guess let's kind of work through that process. When does the field provider know I should be using this DOA protocol rather than this field termination protocol? What things in your guys' mind should trigger us to say,
Well,
obviously they're liquified, right?
Yeah.
You know,
Yeah.
I
that-
cannot
that's-
tell the difference
but-
between the skeleton and the lazy boy.
Correct, but you know, let's go a little more towards your case, which was we have a body, we've got skin signs, we've got other things.
Right. I actually, we have this in the protocol pretty succinctly. If somebody is not incinerated, decapitated, and in that list of what we refer to as DOA, which is not a field termination,
Right.
that's somebody you don't start a resuscitation on,
Right.
is DNR. If they have a DNR or a doctor's DNR order for comfort care, not DNR arrest, that individual still meets DOA protocol. And then we do list signs of lividity and rigor mortis and decomposition. Those individuals would be considered DOA. So it would be a more obvious death. I just want to reiterate from what Dr. Hill started off by discussing that case that they didn't touch the patient.
Right.
Correct.
They looked at the patient. I believe they called lividity.
They called lividity. They said no rigor. And the claim of the person making the radio call was that they checked a radial pulse. And then through the investigation, it was shown that the person actually did not check for a pulse.
Oh. Yeah, that's unfortunate. I really do want to see people put their hands on patients. When you're talking about it, this was a young woman, and they deserve the benefit of the doubt, and they deserve, a conscious effort to make sure that you are dealing with somebody who's deceased. But not putting a monitor on a young woman that's not rigorous certainly does not meet our criteria for final disposition.
Sure. For this.
Did she survive?
I didn't look into the case, but per the report, there was no information about.
Because my understanding was that they narconized her when they came back, and that she started breathing and was functioning at that point. So there's no reason to believe she probably did not survive, which by and of itself is pretty outrageous.
Crazy, right? Yeah.
So one of my big pet peeves, whether it's paramedics or even in the emergency department, and this is with my nurses, is touch your patients. That's the one big rule, is touch your patient.
100%.
You can learn so much by touching a patient. In the emergency department, my pet peeve is, hey, do you know your patient has a fever? They do? Did you touch your patient? I know they have a fever, not because I looked at the vital signs you charted. I touched the patient, they have a fever. And maybe my touch has gotten better as a dad, but I can tell a patient has a fever by just touching my patient, right?
Oh, mom sure can.
Mom sure can. But the same thing for in the field. You're going to know your patient has a fever if you touch them. You're going to know if they're cool if you touch them. You're going to know if they've got a pulse if you touch them. If it's hard to determine what respirations are, you can touch their chest and feel their chest move for respirations. These are all, you have a very great and fine sense of touch on your fingertips where they should be, that you need to put those on your patient to appropriately assess your patient. It's not eyeballs from the door. We've talked about that. We've talked about the doorway assessment as you're going in, that you can learn a lot of information, but the fine details, you have to be next to your patient. You need to be listening to them. You need to be touching them. You need to be auscultating them. You need to be palpating them. You need to be doing all those things for an appropriate assessment of your patient.
And they need to apply the monitor, I think, is the biggest part. It's 4 stickers. It's not invasive. It doesn't take a lot of time. They need to always apply the monitor unless we have obvious, decomposition or they have any type of decapitation. Then they need to be placing that patient on the monitor, because what's your strongest defense? We talk about documentation and how we upload all of these things into our chart. Well, if I put the patient on the monitor, I can upload that strip now into my health EMS report or ESO or whatever electronic medical record that you're using. So we use that as evidence. So like in my organization, I'm huge on that, because I just went on a DOA the other day with our crews, and they put them on, and I was very happy to see our crew put a 4 lead on, and they looked at it, they confirmed it in 2 leads, and then boom, I see the medikit transmit and upload right to the chart. Done deal. Because we're importing.
You've got objective fallback on.
Plus
on
all
that
the
case.
things you mentioned, but now I've captured that and attached it into their medical record. So when someone says, "Did you do this?" It's right here. I imported it into my chart. This is an easy tool that we can utilize.
And that's timestamped.
Right.
Yes, and then it follows up with the correlation of the call.
Yep.
You know, we've done everything that literally just went on this 2 shifts ago. We've done everything that you've said. We've applied the monitor. The monitor's on the bed. Now we're on the phone with UH Geauga. This is who we are. We have
Right.
this person. We ran down the entire
I love
list.
those reports.
We have we've confirmed a systole in
Yep.
2 leads. We have no respirations. We have no pulse. We have this. And then, okay, time of death, boom, and upload. And then we said we were given a time of death over the radio, which further timestamps it.
Yep.
So these are the little
Yeah.
things where we can help integrate these items into your report, and then that protects you. But we have to, the providers there need to do all of those things that both of the physicians
I
have
can't
listed.
tell you how important what you're saying is. For example, Portage is pretty well covered, but you have some single coverage, I imagine, there.
Doc-wise?
Yeah.
Yep.
And we don't have a lot of single coverage where I'm at, but my daughter, who's an ER physician at Geauga, where you're just talking about, it's all single coverage. And so she actually was talking to me that they called for a time of death. They didn't have the 12. They didn't have 2 leads on. They didn't give her a proper examination, and so she's asking them all these questions. And they were like, "Doc, we're just needing
We
a
just
time
need time
of
of
death."
death.
And
Just give me what I want.
and she was like, "Well, I don't give that without recognizing." And God bless her for being that thorough,
Pushing, yeah.
But she called me up because I get a lot of calls from my daughter, and she was like, "Dad, well, isn't there a protocol?" And I go, "Yes, there is. And nowhere is it more important than what you're saying than when you have a single coverage rural emergency department that requires you to be succinct, give us the information so that we can give you that time of death if that's what's appropriate."
I look at this as no differently than if I'm calling you for something outside of the box for medical command. So
Right.
maybe I want to give a drug, or maybe I've given this drug, but I think they need more. Hey, when I call, I need to be pointed. This is what I have. This is what I've done. I think they need more of this. Do you agree or disagree? Because, my patient's getting worse.
100%.
Like, you have to be pointed and organized to deliver that information and confident, because if I call you...
You're not going to get that order, by the way, if you call
Correct.
me and you don't know what you're talking about.
100%. I look at it that way. If I hem and haw and say, well, I don't really know what to do, you're going to say, well, just bring them here then. Because
Right.
you don't feel comfortable with me on the other side of the phone.
And you've got 20 other things happening.
100%. There's
Right.
monitors beeping in the background. They're saying, hey, doc, can you read this EKG? This is room 6. Like, you have a lot going on as well. I think EMS providers need to be pointed. The protocol spells it out very well for everything you need to do. And then back to, I kind of want to take a twist on this a little bit since I'm like harping on the monitor, is we do have some areas where you might only have an EMT in this situation.
Yeah.
And I know...
Yeah.
I mean, a lot of us have a lot of paramedics, but I do
angle,
want to
yeah.
bring that up. But this is where we have the tools to properly use them, where I can apply that monitor as a basic
As
EMT.
as an EMT,
I can
yep.
transmit an EKG to you and say, hey, doc,
Here's what I'm seeing, yeah.
this is what I'm seeing.
Oh,
I'm
they
a-
can
I'm
hook
an
it up for
EMT,
sure. Yeah.
Right.
and transmit it to you, and then you have proof. You're staring at the rhythm on the LifeNet right in the emergency room too. So see, these are some of the other tools as well for EMT providers.
The
So
caveat to that is because I have a lot of basics. in
I just
my
wanted to
area.
open that door
Yeah.
since we
Yeah.
kind of talked about Portage a little
good
bit. Sorry.
point.
The current version of LifeNet does not allow for a 4 lead to be transmitted. You have to transmit a whole 12 lead in that sense. But it's going to be a 12 lead of flat lines.
Of nothing, right.
Which is exactly what I want.
Yep.
I agree with you. That is asystole. There's your time of death.
And that is a great point, and that I don't know that we've stressed that enough in education, right? It's like we give the advanced EMT and the EMT these tools, and really it's packaged up as STEMI management, right?
Yes.
Yes.
But that's another one of these cases. Like, we have the thing, we're just going to use this tool for in a different manner.
But
Yeah.
the EMT
To a new
service,
end.
right? And the EMT services are going to have an AED. And so if an EMT called me up and said, I have a non-breathing, no palpable pulses, central pulses, hopefully they're checking the carotid, and my AED advises no shock, I would be very satisfied with that.
Okay.
So you have kind of steered us a little bit down the BLS versus the
Right.
ALS field termination piece. Before we get down that rabbit hole, we were talking about essentially task saturation of the ED practitioner, and I think there's some. We miss that sometimes on the field side of things, because if I'm calling for a time of death on a DOA, I mean, by definition that's not time sensitive anymore, and then take a minute as the field provider, counsel with your crew there, because none of us work singularly, right? You have a crew there. Let's get that report together and be succinct, like you were saying. Let's walk through this. Hey, what are they going to want to hear? Even if it takes, even if that's take a minute and open the protocol,
Absolutely,
right? And be like, did we do all these things, right? You're going to get a faster response out of you guys, and
And that's no different than when, for you guys in the field calling us for asking questions, and Dr. Spanner and I do in the emergency department calling our colleagues saying, hey, Dr. Cardiology, hey, Dr. GI.
Exactly.
I lead with, this is my question, and then I give you the pertinent information.
Yes,
so that way you know what I'm listening for, whether that's, hey, I need a time of death, here's my report. Hey, I want to go out of protocol and do this, here's my report. And if that's succinct, we give a better, it's a short, it's driven, it's direct.
All right, so back to your point, I agree. And I think this is something that we can teach better. And I think we also teach really well at UH, but sometimes this falls on the organization. When you have a new member, I recently went on another DOA to back up our current squad. We had a lot of volume going on, so I responded. And my probationary firefighter paramedics there, it's an obvious DOA, and we go through the steps of, no central pulses, no breathing. When was the last time you've talked to them? When's the last time you've seen your family member? Oh, it's been at least 24 hours. I came over here because I've not been able to get a hold of them. Right? The patient obviously fell in the basement, was probably deceased since last night, put on the monitor. We have a systole and 2 leads. I said, okay, so this is what we're going to do. You got your whole story, and before you call the ER, I want you to tell me what you're going to tell the physician. And he's like, okay, because I've never done this before.
Right.
I said, perfect. This is a great time to learn.
Yeah, this is the case. Yeah.
This is the case.
There's certainly no rush.
Right.
Correct. The family was not, obviously in close proximity to us, but I think it's one of the things you need to teach, and I agree 100% with your point, is front load the conversation. So when the nurse answers the phone, UH ER, go ahead with your report. Hi, this is X fire department, and I need to speak with the physician for a time of death. Okay, so when they hand you the phone, you immediately know this is for a time of death report.
Yeah, they hand me the phone and say, they need a time of death. Okay, great.
They need a time of death, and then you say, this is so-and-so organization. We're currently on the scene. I have an 85-year-old female that was last seen 24 hours ago. She obviously took a same-height fall. They have not spoke with her. I have a systole confirmed in 2 leads. I have no central pulses. I have no breathing. I've obviously notified the coroner's office. And, do you have any questions for me? So if there's anything that maybe I might have missed, because we're not perfect, we'll forget something, but you're able to do that in 30 seconds, 45 seconds to try to give you the bulk of the information that you want, because I think that's a large part of your world. We only have one patient at this time. You have a whole department full. So I'm trying to be pointed but thorough, but also show I'm confident, we've done this, this is what we've checked. And, is there anything I missed, or is there anything else you'd like me to do?
I like that so much that I'm going to add that to the slide deck. Seriously. So I have a slide deck for next month, just because we want to make sure something like what happened nationally does never happens in our system or anywhere, is why we do these podcasts. But I love that so much that I'm going to have a slide added. So, Dominic, if you're listening, don't put my slide deck out yet. That you should practice being succinct for the physician, so that everything goes the way it's supposed to go.
For all the patients.
For all the patients.
We're focused on that one patient.
Right.
To his point. If we minimize your time, we're helping you help a dozen other patients.
100%.
Right? And that kind of comes down to, that needs to be a competency and a skill set that we should own as field practitioners, right?
Yes.
That is a skill set that needs to be developed, just like
I love that.
Starting an IV, or getting a quality 12 lead, or any of the other hundreds of things that we stress, right?
Mm-hmm.
That's part of our professionalism, is being able to communicate with our peers.
Correct.
Professionally.
Professionally, exactly. Right.
I think another point to bring up, though, is, and you said it, I don't think we, again, focus on it. How long are you checking for central pulses? How long are you checking for apnea?
Right, yeah, very reasonable.
Yeah, that's perfectly reasonable. To
Yeah, yeah.
Again, and then I guess that's the question. How long do you check?
A minute.
Appropriate.
Yeah. Yeah. I was going to go half a minute, but yeah.
Yeah. I'd say 30 seconds is okay, but
is on the low end, right? Yeah.
It needs to be more than just briefly.
Correct. It's not.
That's
not
my
this,
whole
right,
point. Yeah.
Right. It's the closer you are to believing this is death, the longer you should be assessing. Is
I like that.
fundamentally my mindset there.